This presentation will focus on how to do a detailed ultrasound for deep infiltrating endometriosis. The technique described in this presentation has also been published by Manuel Gonçalves and Mauricio Abrao in this publication. It is a good idea to familiarize yourself with the different forms of endometriosis and how they present on laparoscopy, so that you have a better idea of what to look for on ultrasound. During an ultrasound looking for deep infiltrating endometriosis, we look at the uterus and mobility of the uterus, the ovaries and mobility of the ovaries, but also at the bladder, the vesicouterine pouch, the pouch of Douglas, which basically includes vagina, bowel, uterosacral ligaments, and pouch of Douglas obliteration. The uterus and the ovaries will only briefly be mentioned in this presentation, as they are part of the routine gynecological ultrasound, and more focus will be on bladder and pouch of Douglas, because that is usually not covered in a routine gynecological ultrasound. When assessing the uterus, there is probably one image that I would like you to remember: an anteverted retroflexed uterus. So the uterus here is anteverted and retroflexed, and in addition you see that the anterior myometrium is significantly thinner than the posterior myometrium, and the posterior myometrium is very heterogeneous due to adenomyosis in the posterior wall. So an anteverted retroflexed uterus with adenomyosis in the posterior wall should make you concerned regarding deep infiltrating endometriosis, and should be an alarm bell to go and look at the pouch of Douglas in a lot of detail. Where it comes to the ovaries, endometriomas are readily recognized on transvaginal ultrasound currently, and I will therefore not spend too much time talking about endometriomas, but when we see an endometrioma, don't stop the ultrasound there. It is very important to look for associated deep infiltrating endometriosis, because the endometrioma is often the easier part of the surgery, whilst the deep infiltrating endometriosis, which often goes unnoticed, is a complicated part for the surgeon, and so therefore it is very important to recognize the associated findings. Just remember also that endometriomas, although easily recognized on ultrasound, are not always identified correctly. They can be confused with cyst adenomas, with dermoids, or with hemorrhagic cysts. And although it may not give an answer in all situations, and it may not help reliably to distinguish between different types of cysts, I still use acoustic streaming to have a look at a cyst that is homogeneous ground glass appearing echo filled. By putting a color box over the cyst, the particles may start streaming. That is called acoustic streaming, and endometriomas usually do not display acoustic streaming. So if something looks like an endometrioma but it displays significant acoustic streaming, it's not a reason to say it cannot be an endometrioma, but I would have more doubt, and therefore I would go and look very carefully for associated lesions, which then may confirm or lessen the suspicion of an endometrioma. The other thing to look at with ovaries is mobility. Although in isolation a slightly less mobile ovary is probably not a very significant finding, because there can be many reasons why the ovaries may be not so mobile. If there is too much pain and you don't dare to push hard enough, or if the angle is slightly awkward so that you cannot sort of make the ovary move by pushing on it reliably, then probably that is not such a relevant finding. But obviously if you see that the ovary is clearly stuck here to the side of the uterus, then that's a finding worth reporting. And here you can see that the ovary is clearly very mobile. There's a little bit of fluid around it, but when we push, the bowel and everything slides really nicely over the ovary. The next thing I examine usually is the bladder, and the bladder is this fluid-filled structure at the front of the uterus, and I look just at the bladder wall, and this is an example of a normal regular bladder wall that is sliding. So just looking through the whole bladder from left to right, and then at the end I just push a little bit on the bladder as well to see whether the vesicouterine pouch is sliding nicely. And it will be more clear when we look at an abnormal example. The main reason why lesions in the bladder are missed is because they are uncommon, and when we do an examination, because we don't see very commonly pathology in the bladder, we start skipping the assessment of the bladder, and so therefore it is very important, if you don't want to miss lesions in the bladder, to have a very systematic approach to the ultrasound when you look for deep infiltrating endometriosis, and make sure that the bladder is always part of your assessment. So this is an abnormal bladder. So this is uterus, there's a bit of urine here. This is the bladder wall, and it has this big nodule. And very often when there is a bladder nodule, you will see a connection with the uterus. So this is coming towards the nodule here. This is the normal bit of bladder, but here see this hypercoic sort of track that connects up to the uterus. That's where the endometriosis often started before it started growing through the bladder wall. And you can often identify that connection. The next area to look at is the pouch of Douglas, and that's probably the most important area to focus on, as a lot of endometriosis will occur in the pouch of Douglas. It's the most common area to find it. So the pouch of Douglas is the area behind the uterus. It is actually the lowest part of the pelvis. Just here, this little pouch behind the uterus. When we do a laparoscopy, we actually readily see this pouch, because what surgeons often do is they put an instrument in the uterus and ask an assistant to push the uterus forwards in a very anti-flexed position. And that exposes this area behind the uterus. And that is why on most laparoscopic images, the pouch of Douglas is very easy to see. So just looking at what defines the pouch of Douglas, basically it is the little pouch here behind the vagina. So the peritoneum comes down on the uterus, and it goes on the posterior wall of the vagina, and then it will fold back and run along the bowel. And so this pouch here is the pouch of Douglas. So basically the front wall of the pouch is sort of the posterior cervix and the posterior vagina. The inferior wall of the pouch of Douglas is the rectovaginal septum, which is where the rectum and the vagina are fused. And the posterior wall of the pouch is the bowel wall. And then laterally you have the two uterosacral ligaments, which run from the uterus to the pelvic side wall on either side of the bowel. And so this area is defined as the pouch of Douglas. The uterosacral ligaments insert into the uterus approximately at the level of the internal os. So you see that here better on cross section. This is where the sacrouterine ligament inserts. This is where the internal os is, the external os, the vagina with the anterior fornix and the posterior fornix, and then the body of the uterus. And so looking from the back, you see that the two uterosacral ligaments run on either side of the bowel. And if we look at a laparoscopic image, this is the uterus. As you can see, it is pushed forward by the assistant with the instrument in the uterus. That exposes the pouch of Douglas, which is basically made up of the uterosacral ligaments, which form an arch. They're not always as easy to see on laparoscopy. Not every patient has as defined sacrouterine ligaments, and they go alongside the bowel on either side. This is the bowel here, and there deep down is the back wall of the vagina. That's this area here, which is usually covered by a little bit of fat. And then on either side you find an ovary, and this is the fallopian tube. So when we want to assess the pouch of Douglas, what we want to look at is the back wall of the vagina. We want to look at the bowel. We want to look at the uterosacral ligaments, And then we want to see whether there is any evidence of pouch of Douglas obliteration. And basically, pouch of Douglas obliteration is where the bowel or other structures from inside the pelvis are stuck to the posterior uterus, and in that process they obliterate the pouch of Douglas. So if this bowel here is stuck to the back of the uterus, then you can no longer see the pouch of Douglas on laparoscopy. That is defined as pouch of Douglas obliteration. To assess the pouch of Douglas, this maneuver is probably the most important one to remember. When we do an ultrasound, very often we will put the probe in the anterior fornix, and we look at the uterus, we look at both ovaries, and then the scan is considered done and the probe is removed. Whilst if at the end you put the probe in the posterior fornix, then you have a chance of seeing all the pathology that may occur in the pouch of Douglas. So the first thing you see when you put the probe in the posterior fornix is the vagina. The vagina is just stretched over the vaginal ultrasound probe as soon as you put the probe in the posterior fornix. So here we're going to put the probe in the posterior fornix, and you see that the vagina here gets stretched over the probe. And so the vaginal wall here is thin. So again, we put the probe in the posterior fornix, and this is the vaginal wall, a hypoechoic layer with a hyperechoic layer overlying it. There's a little bit of fluid in the pouch, which makes it easier to see the actual vaginal wall. But you can also see the vaginal wall when there is no fluid. Here, that's the vaginal wall, the hypoechoic layer with the white line surrounding it. And then when you push, you can still see that all of this is sliding over the posterior vaginal wall. So just a hypoechoic thin layer with a hyperechoic layer covering it and sliding seen over the posterior vagina. You can also see it when the uterus is retroverted. So this is the vaginal wall. This is the hyperechoic layer overlying the vagina, this transverse section now. And what I do to look at the vagina when the uterus is retroverted is very often I will just give a little push on the uterus and then suddenly pull back, just like here. So you get a bit of fluid between the vagina and the uterus, and then you can see the vagina very clearly. And you want to see that it is regular and not thickened by any nodules. So what we're looking for when we look at the vaginal wall is a hypoechoic thickening where endometriosis has infiltrated and scarred the vagina. It will often be tender if we see a nodule, but it's not always the case. So this is an example. You put the probe in the posterior fornix, and the first thing you see is this really thick hypoechoic nodule, which is a nodule that has infiltrated into the vagina. And so when we then move the probe to the sides, so there will be normal vagina, not all the vaginas. This here is a normal vagina. This is on one side. And that's just a normal hypoechoic layer with a white layer over the top. And then going over back towards the nodule, suddenly you will see the nodule come into view, and it really thickens that vaginal wall here. And then when you go completely to the other side, you again find a little bit of normal vaginal wall. So this is a typical vaginal nodule. Looking at the bowel is also an important part of looking for deep infiltrating endometriosis, because if there is a lesion on the bowel, it is very crucial for the surgeons to know this in advance, as they may require the help or the presence of a colorectal surgeon at the surgery. So just refreshing the anatomy. So these are the uterosacral ligaments. The bowel runs in between both, and then from there it will often go to the left and up. And with ultrasound, we can probably assess approximately this area of bowel. Approximately 25 to 30 centimeters of bowel can be assessed with ultrasound. Now, the majority of the lesions on the bowel will occur just where the bowel runs alongside those uterosacral ligaments, because what often happens is that there will be a lesion forming on the uterosacral ligament, and from there it may grow into the vagina, it may grow into the bowel, or it may make the ovary stuck to the uterosacral ligament. So this sort of area here is the main area where endometriosis will occur, and this level here is approximately 10 to 15 centimeters away from the anus. So when we look at the bowel has on ultrasound 3 distinct layers. So there is a muscularis layer, that's a muscle layer, and if you look very carefully you can see that there's a hyperechoic line running through the hyperechoic muscularis layer that separates the external and the internal muscle of the muscularis layer. Then there is a submucosa which is hyperechoic, and then the mucosa which is hypoechoic again. And then at the back wall it's the same thing. There is a mucosa layer, a submucosa layer, and a muscularis layer. So endometriosis will grow from the outside in, and so it's a hypoechoic lesion that will form on the muscularis layer of the bowel, and it will start pushing the submucosa layer inwards, as you see here. And eventually, when the lesion becomes big enough, it may grow through the submucosa and even through the mucosa layer. And when that happens, the patient may experience bleeding from the bowel during her periods. And it is at that time that the lesion can also be detected on colonoscopy, because a colonoscopy in this situation will be normal because the lesion is completely outside in the outer layers of the bowel and is not breaking through the inner layers of the bowel. So sometimes you just see the bowel lesion. You're doing your scan and you just see the lesion on the bowel just here. Most of the time, however, you have to go and look for it especially. And it's surprising because if you do the scan, you may easily miss this, and you may easily miss this lesion, although they may be obvious now because I point your attention to it. When we do a scan, we are very focused on the area of interest. And if we're looking at the uterus, you will be looking here, and you may not see what's going on just beneath the uterus. So already, if you do nothing different, but just make sure that you look behind the uterus as well, not just at the uterus, then you may already detect some bowel lesions. But unfortunately, most of the time, you will not accidentally see the bowel lesion. You have to do an extra maneuver or some extra effort to actually go and identify bowel lesions. So the first extra maneuver that you can do is what we talked about before, which is putting the vaginal ultrasound probe in the posterior fornix, because then you're close to where the lesions are going to be. And what you're looking for, the lesions that you can recognize by putting the probe just in the posterior fornix, is a bowel lesion that is stuck to a uterosacral ligament nodule, or as I said, often you have a uterosacral ligament nodule that may infiltrate into the bowel, cause a bowel lesion, and into the vagina, cause a vaginal nodule. And very often you will see that the ovary, the inferior margin of the ovary, may be stuck on there as well, often without an endometrioma. So it's sort of that triad of symptoms, triad of findings really, where the vaginal wall, the bowel, and the ovary or the sacrouterine ligament are sort of all involved, is what we're looking for. So this is putting the probe in the posterior fornix. This normal vagina here, this is sliding nicely, but if you then go to the sides, this is still all normal vagina, you suddenly see this big nodule coming into view here with a bowel nodule stuck to it. So this is a very large nodule in the vagina with a bowel nodule stuck to it. So it is important when you put your probe in the posterior fornix that you don't just look in the midline, but that you actually put your probe all the way to the left and all the way to the right. And very often the area of the nodule will be painful, but it's certainly not always the case. Sometimes women will have no symptoms or will just have infertility as their symptom without any significant pain. So again, putting the probe in the posterior fornix, this is the same vaginal nodule as before, but you see now also that there is actually a bowel nodule stuck to it. And so this is the vaginal nodule, this is the bowel nodule. Just again here the bowel nodule stuck to the vaginal nodule, and there's usually a uterosacral ligament nodule in between, but that is sort of more advanced. That's the bowel nodule now being measured. And so it's not uncommon when you see a vaginal nodule to see the bowel stuck to it and infiltration into the bowel wall at the same time. So this is a submucosa layer overlying the muscularis layer, and that looks intact. Putting the probe in the posterior fornix of the vagina will allow you to see those lesions that we mentioned before, the lesions where the bowel is stuck to a sacrouterine ligament nodule or a vaginal nodule. There are, however, lesions that can occur on the bowel that cannot be seen by putting the probe in the posterior fornix. So if this is normal bowel, a bowel lesion can occur on a free-lying loop of bowel that's nowhere near the sacrouterine ligament, and because it's often not stuck to anything, the lesion will start to grow and retract and cause scarring, and that will make the bowel sort of start to curve, and eventually it can almost do a 360 on itself with a scarred sort of retracted lesion in the middle. To see those lesions, the best way is to look at the bowel systematically. So basically pulling your probe almost out of the vagina, starting at the anus, and then angling the probe a little bit backwards so that you identify the bowel, and pushing the bowel back into the vagina, keeping your eye on the bowel as a tubular structure, and mainly keeping your eye on the muscularis layer, because that's where we expect to see the lesions. So like this. So if you start this clip, we're with the probe at the end, the probe is at the entrance of the vagina, just here angling backwards, and we start identifying the initial part of the bowel. This is the muscularis layer. So when we start this clip, we push the probe further into the vagina and keep our eye on the muscularis layer. So here you sort of see the muscle layer here, and you follow it as a tubular structure, and sometimes you see it in cross section, sometimes in longitudinal section. So but you keep your eye on this muscle layer, and again here, and you can go further, and usually you can examine about 25 to 30 centimeters of bowel this way. And as I said, the majority of lesions will occur 15 centimeters maximum above the anus, but the free-lying loop of bowel lesions can occur a little bit further along. And you can see it more easily when you see this abnormal clip. You follow the muscle layer, and then suddenly there is this thickening, this hypoechoic nodule on the muscle layer, which is a lesion on the bowel. And this is just where it's stuck to the vagina. So this is a typical bowel lesion. But as I said, there are lesions on free-lying loop of bowel. Usually they have sort of that shape where they sort of, particularly when they're bigger, where they start to curl up on themselves. And so again, here with the arrow, I'm showing the patient in this clip. So basically, following the muscularis, continuing to follow the muscularis. A little bit more difficult because there is a little bit more gas in the bowel, but you can still, when you try, you see definitely the bowel quite well, and you follow it, and then you start seeing something coming into view here, and it's very obvious. Suddenly there is this big lesion on the muscle layer of the bowel, and you can see the submucosa overlying this, the white layer, and you can see how it goes through the submucosa here, because there are these black lines going into the submucosa. That sort of endometriosis trying to infiltrate, and sometimes you see that everywhere. You see sort of infiltration. They call that Indian headdress, and it's sort of like all little black stripes going through the submucosa. Sometimes it's very subtle, and it's certainly not always easy to see, particularly if there is a lot of bowel gas. But if we see a bowel lesion, it's important to measure it in 3 dimensions. When I do the systematic assessment of the bowel, I try and estimate the distance from the anus. Basically, I measure, I freeze the image, I measure, I then push the probe further and try and continue to measure bit by bit, just assessing how many centimeters there are before I get to the lesion. It's not extremely accurate, but it gives the surgeons an idea of approximately how far away it is from the anus, as that may influence the surgical technique they use and whether they remove it at all, because the closer it is to the anus, the more difficult it becomes to remove, and particularly if it's closer than 7 centimeters, then it becomes very difficult to remove. We will also try and assess which layers are affected. That's probably something that you start doing when you get more experience in looking for deep infiltrating endometriosis, and then describing whether the bowel is stuck to something. Is it stuck to a vaginal nodule, to a sacrouterine ligament nodule? Is it stuck to the uterus, to an ovary, or is the lesion in a free-lying loop of bowel? And particularly when it's in a free-lying loop of bowel, that's important to mention that to the surgeons, because when they do a laparoscopy, the patient is put in what we call Trendelenburg position, which is head down a little bit, and so then the bowel gets all pushed out of the pelvis under the diaphragm. And therefore, when they look into the pelvis, the lesion on the bowel may actually have been pushed out of view. So if the surgeon knows in advance that there is a lesion on the free-lying loop of bowel, they will pay more attention to all the bowel. The next thing to assess is whether there is pouch of Douglas obliteration, and we assess that by looking at the sliding sign. Basically, the pouch of Douglas, you know, is this little pouch here behind the uterus. It's not really behind the uterus, it's behind the posterior vagina. And so we want to see that nothing is obliterating this pouch. And the obliteration usually happens because the bowel is stuck to the posterior uterus, or the bowel is stuck to the posterior vagina. And therefore there is no sliding seen between the uterus and the bowel, but also importantly between the posterior vagina and the bowel. So it is this area here that we want to see nice sliding. This is a clip demonstrating a nice unobliterated pouch. There is nice sliding seen between the uterus and the underlying bowel. So you see the sliding all along here, just here. And there's a bit of free fluid in the pouch as well, which outlines the posterior vagina, and that is also not stuck to anything. So this pouch is completely unobliterated. And it is easier to assess when the uterus is anteverted, but it is also accessible when the uterus is retroverted. So here the uterus is retroverted, but there is some fluid. But what I do is I push on the fundus of the uterus and then suddenly pull back, as I did before, and you will see it again. So this is the retroverted uterus, and there is fluid everywhere. So this is clearly unobliterated in cross section here through the vaginal wall, bit of free fluid. So the posterior vagina is also not stuck to anything. And I'm just going to let the start of this clip play again, because that's an important maneuver to look for pouch of Douglas obliteration, is sort of to give a little push on the uterus and then suddenly pull back, because then you suddenly see the fluid sort of build up in that space of the pouch of Douglas. Here there is less fluid, but again you push on the uterus and you pull it back, and you see that fluid fill that space behind the vagina, and that gives you the confidence to say that nothing is stuck to the posterior vagina and nothing is stuck to the uterus. You can see clearly that there is free fluid filling the whole space. This is the other end of the spectrum. You already see that the uterus is in this it is in an anteverted retroflex position, as you can see here. So already that should alert you to the fact that there might be endometriosis behind the uterus, particularly because the posterior myometrium looks thicker than the anterior myometrium. And so when we play this clip further, you can see that indeed everything is stuck here to the posterior uterus, and that this pouch is completely obliterated, and that there are adhesions all the way up to the fundus here. Same thing here. You again see a thick posterior myometrium with adenomyosis, and when you go and try and push this off, all this bowel is tethered towards the uterus. It's all completely stuck, nothing is sliding. Sort of here again, pushing all this fatty tissue, everything is stuck to the back of the uterus. So there is complete obliteration of the patch of Douglas, just looking here for sliding, which we cannot see. It is not always so simple with patch of Douglas obliteration, because it's a spectrum really. It's not either completely unobliterated or completely obliterated. There is quite a bit in between. So this is the unobliterated patch with the uterosacral ligaments. The uterus is here and the bowel, and there's clear access and clear good view of this patch. This is the complete opposite end of the spectrum, where the uterus is just seen there, but there is bowel all the way stuck to the back of the uterus. Everything is obliterated. You cannot see or recognize a patch at all. But there is quite a bit in between. So here you can actually see the uterus, and you can see that the patch is here, and these are the uterosacral ligaments, but there is just a little bit of bowel up stuck to the sacrouterine ligament. So you'll see that on ultrasound, and that is an important thing to mention, even though there is no complete patch of Douglas obliteration. This is probably an unobliterated patch with some adhesions of bowel to the uterosacral ligament. Here it's a little bit harder to judge. I mean, you can still see behind the uterus. You see the two ovaries, you see the tubes and the uterus, and there's something to be seen, but it's not quite as deep as this normal patch. Here there are actually adhesions up to where the cervix is, and so you don't see the uterosacral ligaments, and you cannot actually see into the patch, and so therefore this is also a degree of patch of Douglas obliteration. But you can see that if you're going to assess this by ultrasound, the fundus of the uterus is still free, and therefore that will slide freely over the underlying bowel, and that's why it is so important to also look at the cervix and the posterior vagina to see whether they are actually sliding. So this is an example where you still have nice mobility of the fundus, but then, so the fundus is moving, but you see that the ovary is stuck, and then here behind the cervix, all of this tissue is stuck to the back of the cervix. So, but going back to the fundus, you can see that there is nice sliding seen here of the bowel, and there is a little bit of free fluid there. So basically this patch is obliterated, but probably with adhesions up to the cervix, and the ovary stuck just above the cervix. Similar here, no problem seen with the fundus, but you can see that this here is all stuck to the uterus. This isn't sliding, this is moving with the uterus here as well. So here you see that there are adhesions to the back of the uterus, probably up to this level here. So it is important to look at the posterior vagina and the cervix to make sure that that is also sliding, not just to look at the fundus. Here you can see even better sliding here at the fundus, and almost all the way up here. But then look, when you go to the side, all this bowel is stuck to the uterus, and there is a bowel lesion seen there. So although that may not completely obliterate the patch, it will make the bowel stuck to at least one side of the uterus, and therefore that will partially obliterate the patch of Douglas. So it's important not to just look in the midline for sliding, but to go to the left and to the right side, and to go behind the cervix, so that you can see that the fundus is sliding, the cervix is sliding, the vagina is sliding, and on the left and the right it's all the same thing. And otherwise describe where you see the adhesions, whether they come all the way up to the fundus or whether they're only up to the cervix, because that gives the surgeon an idea of what to expect. We can look at the uterosacral ligaments and the posterior vagina for smaller lesions, just smaller nodules, and I have taken that out of this general presentation because that's probably the hardest thing to look at in isolation, and there is a different presentation just looking at subtle findings in the patch of Douglas that you can find on the same channel. In an endometriosis assessment, it's probably also important to look at the kidneys, because endometriosis can grow on the ureter in the pelvis and therefore obstruct the ureter, and it can cause silent hydronephrosis. So looking at the kidneys is probably a good idea, because it may not cause a lot of pain, but it can cause quite a bit of destruction to the kidney. And the ureters can sometimes be seen. I have a clip here of a dilated ureter in my next slide, where there has been a stent inserted, and that makes it a little bit easier to follow the ureter. So this is the ureter here with the stent, and you can see that that ureter is dilated. The stent goes here through this clump of endometriosis, where it then becomes a normal caliber ureter. And then we can see the stent still here. This is the stent here and the stent here, and that's where it goes into the bladder. So the first part of the ureter is fine, just here, and then going back, where it goes through the nodule of endometriosis here on the pelvic side wall, the ureter gets squashed, and then here you see that the ureter is dilated as the ureter comes through this nodule. You see that the ureter on the other side of the nodule is dilated, and you still see the stent in it. It's much easier to see the kidneys than the ureters. So just looking at the kidneys to make sure that there is no hydronephrosis is probably a good first step. And if you have a linear probe to look at the appendix, then the appendix can also have endometriosis. It is usually easier to remove from the appendix, as no special preparation or bowel prep is required for a removal of an appendix. Neither is it necessary to have a colorectal surgeon present. So in summary, if we do a detailed assessment for endometriosis, we look at the uterus, and particularly our attention is attracted when we see that the uterus is fixed, retroflexed, and that there is adenomyosis in the posterior myometrium. We will look at the ovaries, mainly looking at mobility of the ovaries, but not get too worried if it's a less mobile ovary in isolation. We also look at endometriomas. Then the bladder, it's important not to skip it. We don't find lesions on the bladder very often, but if we do, the urologist needs to be present at a surgery, so it's important to detect them. It's easy to forget to look at the bladder, so a systematic approach is very important when you look for endometriosis. And then going to look at the area behind the uterus, so the vagina, is there a nodule on the vagina? Are there adhesions in the pouch of Douglas, or is the pouch of Douglas obliterated? And there I think it's important to describe where you see the adhesions and up to what level. Is it up to the posterior vagina, the cervix? Is it all the way up to the fundus? Looking for sacrouterine ligament nodules, that has been the focus of a different presentation that you can look at, which is titled Subtle Findings in the Pouch of Douglas. And then looking at the bowel, is there a nodule, and describing the size, the distance from the anus, which layers are affected, and whether it's adherent to anything. And then looking at the kidneys for hydronephrosis. So I think we can see quite a lot of deep infiltrating endometriosis, and it is more common than we think, particularly in patients with significant symptoms of endometriosis, dysmenorrhea, dyschezia, bleeding from the bowel, or infertility. So it is important in those women to have a detailed look also at the pouch of Douglas. And it is not the size of what you're looking for, but knowing where to look that will help you find it. So I would like to thank my son Peter for helping me edit my video clips, Carl for making beautiful schematic animations and diagrams, and Luke, my husband, for providing me with the images from laparoscopies. For more information, feel free to go to safe-endo.com.au.